Okay. Okay. So what we're going to do tonight is we're going to talk about this module 1C about inflammation, infection, and immunity. When they talk about it, I was mentioning just a little bit ago that we're going to talk about anaphylactic shock, sepsis, septic shock, and multiple organ dysfunction, like which is MODS, and then DIC. These are all we're going to focus on tonight. Is this section, and you're going to see why here in a minute because it you want to make sure that you go into this understanding it. This is something that you probably are going to see again on the boards, and they do like little case studies to walk your mind around it. So you have seen in times past, like in this program, you've probably seen hemodynamic shock, but we're going to talk about something a little bit different, which is called anaphylactic shock. Okay. And this is, if you see the term anaphylactic shock, it says it's a type of distributive shock. Okay. Now, I, I'm going to ask a question and I don't expect any answer from anybody because I am recording this. But if you do want to answer and you feel like you want your voice to be on there, that's fine. But what I want to point, and let me go here and I'm going to go find my handy dandy notes. Because what I'm going to do is I'm going to talk about what shock is first so that that will help you. This is actually not specifically your content that you need, but it's going to be the same. And then we're going to go look at the ATI book. So what I want you to know is that what is shock, right? Essentially, any kind of shock that the patient has is inadequate tissue perfusion, which means that all of a sudden the organs and the tissues aren't getting, look at oxygen and nutrients. They can't remove waste products. The blood, probably the blood volume could be low, and you'll see why here in a minute. And it says vasodilate and vasoconstrict to regulate blood flow. So there's a lot going on when shock occurs, but mostly it's that blood isn't making it around the body for some reason. Okay. So if you'll look here, it says it affects all body systems and can progress to organ failure and death unless the body tries to compensate or we do something to reverse it. Now, the body's very smart. It will try to compensate to a certain point. And you'll see that here in just a minute. But it says usually what will happen, and I'm going to just say this for uh, test sake, is that first place you might notice shock is because the blood volume is not there, you might see it in the urine output. Okay. But remember, the kidneys get like 25% of immediate cardiac output. And so if the kidneys are, if you're not peeing out like you should, probably going to see it because it's a drop in blood volume. Okay. So look, it's not really, when you're thinking of shock, it's not really a single clinical entity, but a life-threatening response to alterations in circulation. So something has caused the circulation to be altered in some way. And for you, for this exam, it's going to be anaphylactic shock, and we'll look at it. But I want you to see this. The microcirculation. A lot of times we don't think about the microcirculation, which is the portion of the vascular bed between the arterioles and the venules, the very tiny little portion that transfers oxygen and carbon, right? It says it's the most significant portion of the circulatory system for cell survival. And if you notice here, it says delivery of oxygen and nutrients to the cells. This is exactly what the microcirculation does. You don't have to know all of this, but I'm just going to point out a couple of facts. Now, you, and we might have talked about this before, there's a couple different kinds of shock. There's something called hypovolemic shock, which you guys had on an exam earlier, where it's a low blood volume. Okay, for some reason, maybe you got stabbed and you're bleeding out or whatever. There's something called cardiogenic shock, which I think we talked about. The pump is not working correctly, the heart pump. But for this test, you're going to talk about distributive shock, okay, which is anaphylactic shock. Now, I do want to ask a question if anybody wants to answer it. I'm recording this to put on Coach Tammy so that you can watch it if you choose to watch it again. I don't know how, I just wanted to do this one because I felt like it's pretty it's a pretty important one. But when you go through anaphylactic shock, I want you to think of somebody who's very allergic to something, right? What happens is all of a sudden they eat something or they touch something or they get stung by a bee or whatever that causes their body to go into this distributive shock. And the word distributive just means pretty much all over, if you'll think about it. So what I want to do is I'm going to go find my distributive shock and I'm going to show you. Let me go down here. Most of the shock is actually already on my Coach Tammy. It's just that I'm specifically pointing this out for you guys, okay? So here's anaphylactic shock. Anaphylactic shock is usually from a severe allergic reaction. And what happens during this is kind of important for you to know that whatever a person is allergic to, it will release, and it says antigens initiate an antigen antibody response, which releases a massive amount of histamine. Now, you guys know from studying pharm that there's something called histamine blocker, right? That's like your Benadryl or something blocks histamine. But what you may not know is that histamine is a potent vasodilator, okay? And that's important to know because if we massively produce histamine in our body, we're going to massively vasodilate. A lot of people think that patients die because they vasoconstrict and they can't breathe, which is true. They can't breathe. But what happens is the chest will constrict, but the rest of the body will massively vasodilate. And there is no blood flow around the body to the organs. And it's because of that excessive histamine. Okay. So that's kind of important to understand because, what really causes it is part of the battle here. And when we massively vasodilate, we lose blood pressure. So our blood pressure would go down. And we also experience something called relative hypovolemia, which we have the same fluid in the body. Our tank just expanded. So our vessels just vasodilated. So now, remember, probably a couple of sessions ago, I said, we're a pressure system. Our blood pressure will tell us everything about what's going on. As nurses, when we walk into a patient's room, one of the first things we do is take their blood pressure. And we can see by blood pressure kind of a little bit of information what's happening in the patient's body, especially with fluids. So when we're looking at anaphylactic shock, I want you to think massive vasodilation. A lot of patients or students would say, if I said, what happens to the body? Is it vasoconstrict or vasodilate? Everybody would say vasoconstrict, but it's not. It's massively vasodilating, okay? So some of the common things that people might be allergic to would be nuts and shellfish and peanuts and insect bites. And some of the medications that people might be allergic to are ACE inhibitors. And I will tell you just that might show up on your boards. I don't know about this exam, but ACE inhibitors cause me to break out in anaphylactic shock. So I know it really is true. So make sure you are aware of anaphylactic and ACE inhibitors. One of the things is we worry about airway, right? But we also worry about anoxic brain injury, which just means that the brain is not going to get the blood flow that it needs because of this massive vasodilation. So what would we look at? And you guys have already had SVR remember, I think it was just the last test where that's the lower left ventricle measurement. But what you'll see if you're in the ICU is the increased heart rate, decreased SVR, decreased blood pressure. I don't know that you have to remember decreased SVR, but I would say the blood pressure drops because the body massively vasodilates, but the heart speeds up because it's like Where's all the blood? Give us more blood. And the heart just knows, hey, pump faster to try to give more blood. Um, One of the things, a lot of patients will say, hey, I'm allergic. And so you will ask them as a nurse, what does your allergy look like? Or what kind of reaction do you have? Because if it's just you get a little red or something, um, that may not be anaphylaxis. But anaphylactic is where there's something called angioedema where the tongue swells and it blocks the airway. And so just remember, angioedema is maybe a word you might see again, right? But flushing, red, warm face, itching, urticaria, oliguria is very low urine output. So there's a couple facts that you're going to have to remember with this. Watch the urine output. Low urine output is going to be a good sign to you. Angioedema, what is it? The mouth and the tongue swell. And sometimes you can't even shut your mouth around it. There's so much swelling. We do have upper airway obstruction. Oops, here we go. Upper airway obstruction, which could be stridor. That means when they breathe in, it kind of has a high pitched wheeze. And then the wheezing in the lower airways is letting you know everything's tightening in the chest. Now, um, to reduce histamine, you could do a Benadryl. Remember, Benadryl or diphenhydramine is a histamine blocker. And I remember one time, uh, I have severe allergies when I was a kid. I really have. And I remember my asthma doctor said to me, keep a Benadryl with you because if you start having an allergy, just take your Benadryl and that might save your life. And I never knew why, but now I know that it will reduce the amount of histamine production. Now, here's the thing that I want to point out that probably will come along with anaphylactic shock is this medicine right here, which is epinephrine. Now, epinephrine is, and I want to ask you, and in your mind, if you don't feel like talking on screen, then I want you to think, why do we give the patient epinephrine for anaphylactic shock? I want you to think about that for a minute. If you want to say what you think, that's perfectly fine. Um, One of the things that epinephrine does is it reverses what is happening in the body system. Okay. So essentially, what happens is epinephrine is going to open the airway and it's going to constrict the vessels to bring the pressure up. That's how it saves someone's life. Okay. So if you'll see, it'll bronchodilate and it will cause vasoconstriction and will reverse what is happening there. The second thing you would probably do is make sure you get IV. I mean, I think I would get IV access and fluid on board to help fill the tank that is really dry, right? So let's go here, and we're just going to cover this tonight. We're going to look at this, and I want you to see. Let me go back to anaphylaxis, and it says includes priority meds. I think a priority med would be epinephrine, right? What are the clinical manifestations? Increased heart rate, could be angioedema, could be low blood pressure, low urine output. Those are things that would be important. And then how do we reduce the risk, right? We just carry an EpiPen. I don't know. That sounds like to me. But look, it says this is a type of distributive shock where an allergen exposed results in antigen antibody reaction causing massive vasodilation. So they do want you to know that. Common causes. Look, they're giving you what could cause this. An antibiotic. Like today at work, I'm like, okay, you didn't write down any allergies on your paper, but we have you in our chart as allergic to penicillin. And the guy's like, oh yeah, I am. We're not going to give him penicillin, but when someone is allergic to it, it's really important to know. Foods like peanuts and nuts and things like that. Latex, a lot of latex allergies you'll see written on patients' charts. And then I always say, well, what does latex do? And they'll use this, it just makes my skin red. So that to me is not a true allergy. If you had anaphylactic reaction, that would be. And bee stings are one of those. So clinical manifestations, risk reduction. Oh, look here, priority meds, epi, What is diphenhydramine? Benadryl, right? So those are the two. First of all, you give an EpiPen. I wish I had mine here. I do carry one, and you can inject Epi through somebody's jeans, like through their actual pants. Okay, we don't have time for somebody to take their pants off. We give it in the thigh, usually in the upper thigh. And so Epi and diphenhydramine are two of the really important drugs that we're going to give. Now, look right here, methylprednisone, and that would reduce the inflammation that's happening in the body. So probably they're going to give the patient methylprednisone. And then if it is affecting their airway, albuterol will help open that airway up. So you're probably going to get all these meds. There's probably going to be a question on that. Like I said to you, IV fluid if shock, and then oxygenation. Okay, so I'm going to pause. Hang on just a minute. I am going to pause and I'm going to ask you guys some questions, okay? Okay, so we had a little question time there, and I want to talk about SIRS. I call it SIRS, systemic inflammatory response. And I want to talk about sepsis and septic shock and multiple organ dysfunction and DIC. These are all going to be important on your exam, but the reason why I want to do them all together is because they kind of go together. Okay, so let me show you what I mean by that. Let's go here. I'm gonna see if I can find it. Okay, now if we look here, it says I just really want you to understand what septic shock is. You know, I know you guys have heard, ooh, your patient was in septic shock. Well, it's similar to anaphylactic shock where you massively vasodilate. But let's really look at why they do this. It's not as much as let's just look, okay? So it says our patho for septic shock is this. When a person has an infection, let me give you an explanation. So there was this lady who we know, and she had a UTI, but she didn't know she had a UTI for a couple of days. And she was, of course, you know, older people, and they don't make sense when they have a UTI. It's not, they don't present typically like pain when urination and stuff like that. So her son took her to the ER, and she was in septic shock. So here's what happened. The invading bacteria in her bladder multiplied faster than the body could kill it. Okay. As the bacteria is destroyed, toxins are released from the organism, which are usually gram negative, which are pretty powerful, which are potent vasodilators. So this type of shock, septic shock, is massive vasodilation, but not because of histamine. It's because of a massive amount of bacteria that is forming in the body that the body can't work fast enough to kill. And it says it causes an increased permeability of the endothelial wall, which is the vessel, shifting fluid from the vasculature, microvasculature clotting occurs, impaired fibrinogenesis, and widespread vasodilation. So with this one, if you're going to look at septic shock, you just need to know what is causing this one, right? It's a bacteria that is forming, which is a potent vasodilator. Okay, so both anaphylactic and both septic shock, the patient has vasodilated. Now, let's look at this, okay? Because what's the difference? There's a difference here between sepsis and septic shock, okay? So when you have sepsis, life-threatening organ dysfunction caused by dysregulated host response to infection. So what that means is that we're having organ dysfunction because we have this massive bacterial infection, right? Now, septic shock is a subset of sepsis. It's kind of the same thing, but what happens is now this whole circulatory system is involved. It says profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. So at first, the organs are kind of having some dysfunction, and now we got this profound circulatory septic shock. Okay, let's look down here. I want you to see some of the more common sites for septic shock. When a patient, and you guys had this on your last test, I think, the VAP bundle, but pulmonary system, if a patient has an infection in their lungs, then they could certainly go into septic shock. Okay, just know that the bacteria may be too powerful for the patient to hold back. Bloodstream from invasive IV catheters. Urinary system's a big one there. Okay, so make sure you know urinary, like UTI, especially in older people. Man, they can go septic real quick. GI tract and wounds. All right. So what I want you to know, just kind of have a general understanding of what could cause sepsis, but I want you to see what happens here. Okay. Initially, it's kind of a tricky one. Initially, the heart rate will go up, the cardiac output and cardiac index will go up, and then the blood pressure will go up or be normal. At first, you might not see this. As the body compensates, the body is very smart. It's going to try to fix whatever is happening, but it says you won't take very long before you see everything start to decrease. So initially, everything's going to be kind of up or normal, and so you may not recognize it right away. So there is, and this is on your didactic here, we can use two criteria to see if this is sepsis, okay? One of the criteria that's on yours right here, if you'll notice, I thought it said Sears. Hang on just a minute. I'm pretty sure I saw it. Maybe I didn't. Maybe they're not going to ask it. But oh yeah, look, understanding the following continuum related to Sears or Sears, SARS. So let's look at this here. Sepsis is a systemic bacterial infection. It just says that is an example of SARS, how to reduce the risk of sepsis worsening. We'll go look at that. But look at early versus late signs of sepsis. Now, what I want you to do is go to your Pearson book and say, what's the early signs of sepsis and what's the late sign? Because those are in this box right here, apparently. We can look at my notes too. But liquid septic shock is the progression of sepsis. Now, the whole circulatory system is involved in this sepsis. It says, know the clinical manifestations and priority interventions, which we're going to look at. And it says, review the stages of shock. Okay. And then what happens, I'm going to go back to my little notes here because I am going to talk from this one. What I want you to see is, first of all, what Sears, I call it Sears. You can say it sour Sears, whatever you want to say. But SIRS just means systemic inflammatory response. So because of this overwhelming bacteria causing this potent vasodilator, our body starts to roll into this uncontrolled inflammation in the body. Okay. Remember, our body's pretty smart. It wants to help fix it. So it sends in all the like white blood cells to try to help repair what's going on. And so usually when they look at the systemic inflammatory response, they'll either see a body temperature that's lower than normal, like 96.8 or higher than normal, higher where it's a temperature of like 100.4. Our white blood cells, this is kind of weird, could be either really low or really high. And then our heart rate is usually greater than 90. And then our respiratory rate is usually greater than 20. And our carbon is usually low. Now, I want to point something out. This is how ABGs kind of work when you're dealing with sepsis. And I wouldn't doubt it that they ask something about it. First of all, the patient will start with respiratory alkalosis, and then they may move into metabolic acidosis. So be aware, they might start like not as serious, and then boom, now they're over in metabolic acidosis. They have what's called hypoperfusion, where they don't have enough fluid, and their lactic acid will be up. So, but it says true septic shock. You've been fully fluid resuscitated, but you're still having hypoperfusion, which means we give you a lot of fluids, but you're still not showing that in your blood pressure. The blood pressure is still low. Okay, so when we look at SARS or SEERS, however you want to say, that's a systemic inflammatory response that's happening. This you don't need to know, but I'm just going to tell this to you anyways. This is called QSOFA, and it's just the abbreviation for it. But once we start, what we're going to do is we're going to give a scale, a score. The score ranges from 0 to 3, and it says of 2 or more points above the baseline indicates organ dysfunction. So this is what they usually look at right here. It says respiration is greater than 22 per minute. Level of consciousness is, it says up, the little arrow, but I would say it might be down. And then the systolic blood pressure is less than 100. So when we're working in the ICU, if we see those things, we might think, oh, they're going into septic shock. Now, I'm going to scroll down here because I want you to see this. Um, all stages of shock go through certain phases. If you're a really good nurse, you're going to catch it, okay, early. It's very difficult to catch shock early, okay? So we're going to look at what the ATI book says here in just a minute, but this is stage 1, stage 2, stage 3, stage 4. At first, you get this stage of shock where it's called initiation, and we're going to find out what happens during that. Then the body will try to compensate, but it can't compensate for only so long, and then it becomes progressive and then refractory. So let's look down here. I want to just show you something. You do not have to memorize this, okay? But during this stage 1, tissue oxygenation is down, right? Intervascular volume is down. Myocardial contractility may be even down, or the vascular tone may be down. But I want you to understand that, look, clinical presentation, they may not show any clinical indications. Their blood pressure and everything may look fine. They may be urinating fine. So that initiation phase, we may not catch it. Okay. Let's go down to compensatory stage. Nurses with good assessment skills pick up on this stage. It says as symptoms become apparent. So maybe as the body's trying to compensate, you may catch this. It says shock can still be reversed with minimal morbidity. The body is working together to respond to the attack. I'm going to say we may catch it in an ABG, but it doesn't say that there. So here it says, like we have different, if we're looking, which you do not have to memorize this, so I don't want to confuse you, but we have neural compensation, which will increase our heart rate and our cardiac output. So that might be the first thing that you see besides the urine output going down is the heart rate going up, right? And then we would, of course, look at preload and everything. Look what our endocrine system does. This is something that I think might be important as we're in this compensatory mechanism phase. They have an increase in blood sugar. Releases glucocorticoids to increase sugar levels. So for some reason, our endocrine system wants to increase our sugar levels, so it releases sugar. We also release mineralocorticoids, and antidiuretic hormone keeps us from peeing. So at this point, we may say, I'm not, or their patient's not peeing, their heart rate's going up, their blood pressure's going down. We may start to see some of these things, right? They start to increase their rate and depth of respirations, which is really respiratory alkalosis. And then we really worry about cerebral perfusion to the brain. Okay. But then I want you to see that in stage 3, we have this progressive hypoperfusion where we're not getting blood around the body. And it says the systemic and microcirculation no longer work together. So they're not in unison anymore. And then what happens is we change from an aerobic to anaerobic metabolism, and we start producing lactic acid. I know that's difficult to understand, but let me give you a scenario. So my sister had a patient a long time ago, and this person came in to a little minor ER and said, I don't feel very good. And this was during COVID. I just want to get checked out and then go home. And so she checked his lactic acid and it was 9. Remember, the high of lactic acid is like 2.2. And because his lactic acid was high, it told her that he was in shock, in about progressive stage of shock. So lactic acid is a very huge indicator that somebody is going into shock. Now look, this also failed. The sodium and the potassium pump fail. And you guys have known enough about sodium and potassium to know that when salt is low, you have intracranial pressure. When potassium is low, it can mess the heart up. All sorts of things, right? And then look here, systemic circulation will have vasoconstriction and the microcirculation vasodilates. So we both got one system that's not in sync with the other. And then let's just look at the other. Refractory is not good. Like that's really dead. This is severe tissue hypoxia, okay, with worsening acidosis, probably going to metabolic acidosis. So we'll start out with respiratory alkalosis. We can look at our lactic acid and then probably going to end up in metabolic acidosis. This is on your didactic. If we go to the refractory period or refractory stage, which we'll have to see what it says in the ATI book that's called, it may be still called that. Then there's 2 things that are on here. Look, multiple organ dysfunction, which is called MODS, and microvasculature thrombi, which is called DIC. I don't know if you're familiar with that or not, but I can give you a little scenario. Let's go back before I do, and let's look at this, okay? So we know that SIRS is systemic inflammatory response, and with that, or that causes it, is sepsis, right? Which is a bacterial infection that actually is so powerful that the bacteria just multiply very fast. And the bacteria are now the potent vasodilators, okay? Now, when we go into septic shock, that has gone through the whole circulation, right? And it says, what are the clinical manifestations of septic shock? We really need to look at the ATI book and say, what do they want us to know about septic shock? But remember how I said, at first we may not even notice it. And then the body tries to compensate, and that's when you might start to see it. The multiple organ dysfunction syndrome, MODS, is the progression of septic shock leading to failure of 2 or more organs. If unable to reverse the shock quickly, know the clinical manifestations and which 2 organs are the most common to fail. And right out here, it says lungs and kidneys. And then it says the refractory stage of shock. So we were not too far off the path there. There is a refractory period. So look what else it says. Review labs and diagnostics. What labs are we going to run? What would we see? I'm going to say lactic acidosis is going to be a lab because if it's high, that's pretty serious, right? Now, when I get here, and I'm going to go back over this, so don't panic, but I want you to see what is disseminated intravascular coagulation. When you are learning this DIC, I want you to think death is coming. Okay, that's how we used to remember it. For some reason, the body, no matter, like if you start rolling, and you can roll into DIC. DIC is something that the body can just kind of roll into, and it can just kind of happen. There's a couple people who I've known that had it, and they don't usually live. But what will happen is all of a sudden the body will start to clot. It will clot off all the little microvasculature. And then the body makes all these clots and all these organs will clot. And then the body goes, oh no, we got too many clots. Let's unclot. And so all the clotting factors work to unclot the system and then you bleed. So I always say clot, 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 then you bleed, bleed, bleed. Okay. So I'll tell you a story of my sister. She went in to have a baby. It's a long story, so I'm going to skip all the parts. But what happened is when when her water broke, the placenta lifted off, placenta previa is what she had. and some of that amniotic fluid went into her bloodstream, which immediately sent her into this called DIC and sepsis, right? So she started to clot off, all of her organs clotted off. Then the body went, oh, dang. And then she started to unclot, and then she started to bleed. And when I say clot and then unbleed, what I mean is you literally clot off everything, and then you unclot everything, and you can even bleed out of your eyes and your nose. Most people do not live through that. But I'm happily to say she did live, but it has taken its toll on her. So let's look. So if we were to look at the refractory period of shock, the stage 4, you multiple organ dysfunction, which means 2 or more organs are not working, which is usually the lungs and the kidneys. And if one was the kidneys, you would definitely see no urine or very, very low urine output, right? So we would also see arterial blood pressure too low because you've massively vasodilated. But if you look, microvascular thrombi and the development of DIC, look at dysrhythmias because probably your potassium's low, right? There's so many things. And then cerebral ischemia or infarction, probably because your salt's low. Look, hyperglycemia. Remember, we talked about when the body starts to go in shock, sugars will rise. So I think those are really important facts. This is something that ATI doesn't really explain, but I want us to look here so we can kind of see this. Hang on just a second. Okay, so it says um, general assessment of all types of shock. Okay, this is what we're looking at. I want you to see this. When you see the word restlessness on an exam, it just doesn't mean they can't lay in bed. It means that their organs aren't getting oxygen. That's what it means. So restlessness and agitation, anxiety will start to happen in this patient's body. And as shock progresses, they'll become confused and lethargic, and later they'll be unresponsive. Okay, so we just need to know that is what's happening. And once you see in the renal system, they'll experience oliguria, which is really they're not peeing, right? One of the first indicators is urine output. And then let's look here, respiratory system, rapid and deep respirations as shock progresses. And then look, hematological system, clotting in the microcirculatory system. And then the white blood cells obviously are either low or high. So I just want you to be aware that what do? We give fluids and blood, and we have to know how to treat this, right? How to expand volume and all of that. So let's go to the ATI book, okay? Let's see if we match up. Now, it says on your didactic chapter 38, but I'm using the old book. So in mine, it's 37. So you go to your book and you look at your new chapter, okay? So we're going to try, and this is why I'm just doing shock tonight, because shock, it can be overwhelming. It can put you into shock, hopefully not. But look what it says here, and I'm going to pick out some important facts right here. Shock is a state of inadequate tissue perfusion. We are not getting blood to the organs and the tissues because anaphylactic shock and septic shock are both causing the body to massively vasodilate. Okay. Anaphylactic shock is due to the massive amount of histamine. Remember, histamine is a potent vasodilator. But septic shock is due to the tremendous amount of bacteria that's being produced. And bacteria is also a potent vasodilator. So that is why there's not enough perfusion. We still have the same amount of blood. We still have the same vessel, but that vessel has just gotten larger because we are vasodilated, right? And it says it can lead to impaired cellular function and organ failure. That's important. Any condition that compromises oxygen delivery to the organs and tissues can lead to shock. So if you look here, it says shock is a rapidly progressing, life-threatening process. Early detection with rapid response is necessary to improve the outcome. I'm going to ask you here in a minute some questions, okay? So get ready. Older adult clients have reduced compensatory mechanisms. Remember, we talked about the body will try to compensate, but the older you get, you don't do that as well, okay? And then they could either rapidly progress through the stages of shock, which is a little bit scarier for them. Catecholamine secretions might not improve cardiac contractility, decrease ability to compensate. Okay, just know that older adults can't compensate as well. So when we get down here, I want you to pay attention to distributive shock. That's another term for anaphylactic shock. The way I think of it is like, get stung by a bee and it distributes through your body, or the histamine or whatever. So if you look what it says next to it, widespread vasodilation with increased capillary permeability, including neurogenic, septic, and anaphylactic shock. So septic shock and anaphylactic shock are distributive shocks. All right. Those are the two that are going to be very similar. The only difference between the septic and anaphylactic is the cause of it, which anaphylactic is a massive production of histamine and septic is a massive production of bacteria. Okay. So let's look at the stages here. Okay. Mine was a little more complicated, my version part, but this one is what you need to know. Initial, no visible changes in their parameters, only changes in the cellular level. And I bet you that could be a test question because initially you're not going to see it, right? Let's look at the compensatory one. Measures to increase cardiac output to restore tissue perfusion. So your body's going to start compensating. You're going to start seeing the blood pressure drop, the heart rate speed up. You might see sugars start to rise. I mean, if you're working in the ICU, you would probably see they're starting in respiratory alkalosis, then they go to metabolic acidosis, their lactic acid might start to rise, all of those things. And then as it progresses, our body says, well, you know what? We can't compensate anymore. Good luck. And remember, the systemic and the microvasculature stop working together. They work separately now. One is vasodilated and one is vasoconstricted. And then once you get to the refractories, they may ask this question. This is irreversible. This is where you would see MODS and DIC. I honestly, I think you could, if you noticed it in the initial phase, you probably could fix it, but most people don't notice it then. In the compensatory phase, you hopefully will be able to notice it there. And one of the things that I think would stand out is something that's very simple, which would be urine output, right? Like if your patient's not putting out urine output, what's going on? What's happening there, right? Pay attention to their blood pressure, pay attention to their heart rate. Okay, so let's look up here. We're going to look at septic and anaphylactic. Septic shock, let's see what it says here. Advise the client to obtain early medical attention when they have an infection, right? So if you look, one of the things I mentioned, and I don't know if everybody was on here when they heard it, about the older lady who had a UTI and ended up with septic shock. Remember, older adults can't compensate very good. Their bacteria could take over their system fast. And so they're more likely to go into septic shock. It says, advise the client to complete the entire course of antibiotics. This is exactly why you have a patient who has a bad infection complete the whole course. We do not want them to have septic shock. Now here, look at this. Anaphylactic shock, you know what that's from. Bee sting, allergy, whatever. Advise the client to wear a medical identification brand. Yeah, I think I would. Avoid allergens and to have epinephrine at all times. Now remember, what did we talk about? This is what's interesting. Epinephrine is used for anaphylactic shock, but you'd think it worked for septic shock too, but they don't mention it there. I don't know. They might give it. I don't know. I haven't worked with a lot of septic shock. So, but teach the client and family how to use the epinephrine pen. And what did I say? You can put it through clothing. You may not have time to pull somebody's jeans down. You're just going to jab it into their outer thigh. excuse me, and that epi is going to reverse what's happening in the body. Okay, let's go down here. Let's look at the distributive shock. Okay, we're going to go right here. Septic shock. It says endotoxins and other mediators causing massive vasodilation. Most common cause is gram-negative bacteria. I think I'd write that down. What causes septic shock? Remember, if you were with me in farm, gram-negative bacteria are harder to kill. They have 3 layers to them, and it's harder for the antibiotics to get to them. If you look, urosepsis is more frequent in older adult clients due to the increase of catheters in long-term care facilities and the late detection of urinary tract infections. So they have a decreased sensation of burning and urgency. They don't get that. I don't know why they don't have it as much, but we have to look more at their cognition for older adults. Now look, anaphylactic, allergen exposure and an antigen antibody reaction causing massive vasodilation. I'm going to add that from histamine, right? Look at the common causes: antibiotics, foods, peanuts, latex, and bee stings. Same thing that I read to you earlier. So let's look at the expected manifestations, okay? Now, I really want to point some things out. I really want to ask you some questions, and I might in a minute here pause it. But I want to say, what would you expect to see if your patient was going into anaphylactic shock or septic shock? Look, chest pain. I wonder why chest pain. Here's why. It tightens the chest, right? Lethargy, somnolence, restlessness. What did I say? Restlessness meant not getting enough oxygen to the organs. Anxiousness, shortness of breath, maybe sweating, thirst, muscle weakness, nausea, and constipation. Okay, let's go down here. Look at the physical assessment findings here. Hypoxia, low blood oxygen. For this, if we suspect that the patient is going into septic shock or anaphylactic, an ABG would be probably the best way to see the oxygen measurement. Tachypnea progressing to greater than 40 per minute, and then low carbon. Their carbon will go down. First in the mucous membrane, skin molting. Let's see, I'm gonna look here. Clients who have light skin, Clients who have light skin, tones appear grayish blue. Skin can be flushed initially with anaphylactic and septic shock. So they're saying initially you could get really flushed and then you start to be pale. Look at the angioedema. Remember what I said, the swollen tongue, the swollen mouth. That's more with anaphylaxis. Wheezing from the chest tightening could be with both. Look at this, decreased blood pressure with narrow pulse pressure. Postural hypotension, tachycardia, pulse that is weak and thready. Look at that, decreased cardiac output. Central venous pressure decreased, which is your CVP is down. CVP increased with cardiogenic shock. Don't worry about these two. You don't have those on this exam. But look at there, decreased urine output. Okay, so what would I worry about? What do I think they're going to bring up? They might say hypoxia. They might say low carbon, right? You might breathe really fast, tachypnea, 40 per minute. I think angioedema might come up with anaphylactic shock. I also think your decreased urine output is going to come up. Okay, so for you, I would think I would know that. Now, look at the lab test. Remember how I said the most accurate oxygen measurement is through an ABG, right? The P little a O2. But our carbon is also going to go down. That's a good indicator that this person's going into shock. So if you see here, but look what it says here. Decreased tissue oxygenation, which is decreased pH, decreased P little AO2, which is oxygen, but it says increased. Now, see, it just contradicted itself. Up here it says hypocarbia. We're going to have to go and look and see. We'll go investigate that. But look at the lactic acid. That is going to be an indicator to you. That little fellow that went and saw my sister and his lactic acid was 9, he had to go into the ICU. He wasn't going to go home. He just said he wanted to go home. He wasn't feeling good. He didn't think he was going to die, and his lactic acid was high. I want you to see this. They're mentioning this. Look, blood glucose can increase during shock. Electrolyte balance can be altered depending on the cause. Remember, salt and potassium could be altered. Let's go here. Let's go up here. We'll go specific to the shocks that they want you to have here. With septic shock, probably going to look at all your clotting factors, okay? Like your PT, your INR, and your APTT. Going to get blood, urine, and wound cultures because this is caused by a bacteria, right? We have to know septic shock is caused by a bacteria. I want you to get a good picture of a patient because I'm going to ask you about a patient here in a second. And what are we going to do if someone comes into us in shock? Arterial line is going to go in, right? We need to measure continuous blood pressure monitor. So we need a really good pressure, which you can get the most accurate blood pressure too through the arterial line. But we also want to get a pH, carbon, and bicarb. They could do a pulmonary arterial catheter. Remember, we talked about that where the tip of it goes into the artery, right? They could do that. And then with obstructive shock, which would be, you don't have, let's see, hypovolemic shock. I'm trying to see here if there's anything. Hemodynamic monitoring, hypovolemic shock. Let me go here. Let's just go to patient-centered care, okay? What are you going to monitor? So your patient's going into shock. Look at all the things we talked about. Obviously, their oxygen level, right? Because their organs aren't getting oxygen, their microvasculature is not. Our vital signs are going to tell us a huge amount. The heart rate's fast, if the blood pressure's down, if our urine output is low, we probably got something going on. We want to look at the heart rhythm because the potassium could be low. And look, report, and this is giving you a number. Remember, a normal urine output is 30 mils per hour. Report if less than 20 mils per hour. And then we could go into low level of consciousness, skin color, temperature, moisture cap refill, all that. Now, we're going to explain the procedures and findings to the client and family. Place the client on a high flow oxygen, such as 100% non-rebreather mask. I don't know if they're going to ask that, but that's pretty specific. If the client has COPD, insert a 2 liters per minute nasal cannula and increase the oxygen flow. So if they have COPD, of course we can't give them 100% non-rebreather. We can't. Be prepared to intubate. Maintain IV access for hypotension. Place the client flat with both legs elevated to increase venous return. They could ask that. If change in status occurs, notify the rapid response. Prepare for and maintain client care during transfer. Let's see what else we got here. Okay. So we can look. I'm going to go down here for just a second and see what we're going to do. Because I looked at the medicines that were on your didactic. Let's go back here. And like right up here, I think is where we talked about them. Look at our priority meds and interventions, okay? Epi and diphenhydramine, Benadryl and Epi are going to be there. Methylprednisone reduces inflammation. Remember, with SEERS, we have systemic inflammatory response. So if we give them steroids, that's going to help reduce inflammation. If they can't breathe, we can open them up with albuterol, IV fluid if they're in shock, because we got to bump up the pressure, and oxygen. And they're actually talking about oxygen on here. How and what are we going to give, right? So I would say this little thing right here, high flow like 100% non-rebreather. But if they're COPD, we're just going to do 2 liters per minute. Now, we can do, they didn't give these meds, and I'm good. I mean, I don't really think, I don't know if these will be here or not. But what we can do is we can give what's called an inotropic drug to help the heart contract, which helps, increase cardiac output. Because remember, the heart is not really, it's beating, it may be beating fast, but it's not putting out as much blood as it should. But the ones I'm going to focus on are the ones that they gave you. But here, for one moment, I want you to see something that you may have to treat a patient who has one of these shocks with. Is called a vasopressor, right? Remember, we're going to press the vessel shut or put pressure on it. When you press the vessel, you also press the P. So let's look here. It says it causes vasoconstriction, increases systemic vascular resistance, and increases blood pressure. The patient could get vasopressin. I think a vasopressor like dopamine, norepinephrine, and hydrochloride, they're vasopressors, but I think they might ask you about vasopressin, which can be used. It's very similar to epi. If you look, epinephrine works a little bit different, but it says rapid acting bronchodilator. So a vasopressor is not going to open up the airway, right? So when you have this shock, what happens is the airway constricts, but the rest of the body is massively vasodilating. So when you have epinephrine, let's open the airway and let's get the cardiac output going. But we can also bring pressure up because it will vasoconstrict. It actually sends the patient to the sympathetic nervous system, is what epinephrine does, right? And so just be aware of that. Let's go down to, now I'm going to mention something here because I think this could be on one of your exams somewhere. Whenever the patient's body is under stress, whether it's in septic shock or some type of shock, or burn, in the patients like in the burn unit or whatever, the body will sometimes produce stress ulcers. They'll get bleeding ulcers. And so what you'll see is your patient will be put on a proton pump inhibitor, like pantoprazole, as a protective measure to keep the acid down and keep them from producing it. If we do have something like DIC, where we clot, and then we bleed, for the clotting part, we may have to use some anticoagulants, which I think you know. But let me look here. We're not talking about hypovolemic shock yet. Look at our diphenhydramine. Used as a secondary med to treat angioedema, urticaria, which is itching associated with anaphylactic shock. Blocks histamine at the receptor sites. So it's going to keep the body from producing as much histamine. If somebody's already vasodilated, we're not going to give them a vasodilator on this test, right? And then what if, okay, so this could show up. What if, and it says, because septic shock is most commonly caused by gram-negative bacteria, the Joint Commission's National Patient Safety Goals recommends the administration of IV antibiotics that are effective against gram-negative bacteria within 1 hour of septic shock diagnosis. I think I would remember that, even though I didn't see vancomycin listed as a drug. You have to know how to treat your kind of shock, right? So for anaphylactic shock, diphenhydramine, epinephrine. For septic shock, within 1 hour of septic shock diagnosis, we're going to give them IV vancomycin, okay? Intubation and mechanical ventilation might be necessary also, but we're not going to go into that. Okay, now, hang on just a minute. We're going to go find what we need. These are the 2 that we need. So if you go into this test and say, hey, MODS, is the patient in MODS? That just means, are their organs failing? Remember, your instructor listed lungs and kidney. Those are the two organs that fail. Okay. Have you ever heard, you may not, ICU, I don't know if they talk about it too much if you've been there in your rotation, but um, sometimes they'll say their kidneys are failing. You know, that's part of MODS right there because their kidneys are not getting the blood output that they need to survive. Okay. So look at MODS. It says occurs from the release of toxic metabolites and destructive enzymes in response to inadequate oxygen. MODS can develop from inadequate tissue perfusion or severe hypotension and reperfusion of ischemic cells causing further injury. Organ failure usually first occurs in the lungs, okay, and adult respiratory distress syndrome, but can occur in the kidneys and the heart and the GI tract. MODS is most commonly associated with sepsis. So usually if you go into septic shock, your body will have multiple organ dysfunction. Other risk factors include malnutrition, coexisting disease, and advanced aging. All right. So assess organ function. Remember I showed you that little Q-SOFA scale and whatever. You don't have to know all that, but there are ways to assess it and assess organ function and provide support measures. That's what we're going to do. And then let's look at DIC. Okay. DIC is a complication of septic shock. Let's read what this says. Thousands of small clots form within organ capillaries, liver, kidney, heart, and brain. Yeah, like that's almost impossible to come back from. Um, so remember, you clot, 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 then you bleed, bleed, bleed. Okay. So what happens is you get the clots first, creating hypoxia and anaerobic metabolism. As a result of massive multiple clot formation, platelets and other clotting factors like fibrinogen are depleted. It's probably because the body said, hey, we clotted off everything. Now, we clot. Well, you need to unclot. And the client is now at increased risk for hemorrhage. Client can develop diffuse petechiae, ecchymosis, and blood can leak from the membranes in the puncture site. So when our blood gets too thin, the vessel can't hold it anymore and it leaks out of everywhere, just everywhere. So let's look at our nursing actions. Assess the client preference related to transfusion of the blood products. Some clients might not accept this treatment for religious reasons or fear of contamination. Administer platelets, clotting factors, and other blood products. Monitor our hemodynamic levels. You would also monitor your PT, BTT, blood, fibrinogen, all of those clotting factors. And it says assess for further indications of bleeding from mucous membranes, venous puncture sites, gums around IV catheters. So you think about it like this. If you go into DIC, first you're going to clot, 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 and then the body's going to unclot. And could bleed out of your nose, your ears, your eyes, any mucous membrane. Apply pressure to leaking IV central line. Explain procedures. Okay. So I'm going to ask you some questions. I'm going to stop this so everybody can talk.